Right, sounds good. So, hey guys, inshallah, today we'll be explaining to you, or like we're just gonna have small questions and answer session for some pathology questions for your POD midterm exam. Now, Shahd and I have collected almost like every possible question that they could get you on your midterm from like a billion different sources. So it might be a lot. However, I do highly recommend that you guys go through them, at least like if not down in the recording, like at least on your own when we send you the PowerPoints. So like please try to go through them. And if you do have any questions on solving them, you can find my contact number down here along with Shahad's contact number. So feel free to like text any of us for any questions that you have. And with that being said, like we'd hope if you guys could be interactive with us and try to participate, like share us your answers in the chat, and we'll go through them together. So you guys ready to start? All right, let's begin. So let's do the first lecture now. We arranged them according to the pathology lecture that you have. So starting with the first lecture, we're going to be talking about cellular adaptation. So with that being said, let's go to the first question. All right, I'm going to read the question, and then I'm waiting for you guys to answer in the chat. A 53-year-old woman with no prior illnesses has a routine checkup by her physician. On examination, she has a blood pressure of 150 over 95. If her hypertension remains untreated, which of the following alterations would most likely be seen in her myocardium? Right, mashallah, you guys answered it immediately. So yeah, good job. Yeah, basically the answer is hypertrophy. So it's a simple question, straightforward. What happens is that there is hypertension, and with hypertrophy, the main goal is that the muscle is getting stronger. It's an increase in the size and the strength of the muscle. So whenever there is an increased tension, the muscle must be stronger so that it can pump against this increased tension. And the only way to make a stronger muscle is through hypertrophy. So that being said, it's the first question. I'll leave you with Shahad for the second question.
Second question. The non-pregnant uterus of a 20-year-old woman measures 7 to 4 into 3 centimeters. The woman becomes pregnant, and just before delivery of a term infant, the uterus measures 34 into 18 into 12. Which of the following cellular processes has contributed most to the increase in uterine size? You can type in the chat.
Yeah, Maryam. So as you said, it's both hypertrophy and hyperplasia, but like one of them contributes like greatly or like more than the other. So yeah, this is like the point of the question.
Okay, wait. We'll explain it in a bit. More answers? Okay, we got a few A's. We can review the answer. Next slide. Okay, the correct answer here is D. The myometrial smooth muscle hypertrophy. Now, as Maria mentioned, we have both hypertrophy and hyperplasia in this case. Can you go to the next slide, please? Yes. So you can see here in the normal uterus, you can see the muscle fibers. Compared to the gravid uterus in the pregnant lady, you can see the muscle fibers are increased in size, enlarged, which is hypertrophy. Now we have both hypertrophy and hyperplasia. But if you go back to the options, can you go back to the options? You can see here that you have the endometrial, myometrial, the glandular hyperplasia, fibroblast proliferation. Now, what we have mainly in this case is the myometrium. We're concerned about the myometrium. We have hypertrophy and hyperplasia. So the other options in this case do not apply. So yes, we do have increase in glands, but the main change in this case is myometrial smooth muscle hypertrophy and hyperplasia. So we can go to the next question if nobody has a problem with this.
Is it clear for you guys, this question? It's basically like both of them are contributing, it's just like which one of them is contributing more. Like you can think of it, if you find it difficult to remember, you can think of it as like since she's pregnant and she's about to deliver, then whenever you're doing delivery, you want strong muscles so that you can like push the baby outside. So like that's a way to remember that the muscles must be hypertrophied. like if you feel like you're getting confused with it. All right, so the next question. At autopsy, the heart of a 63-year-old man weighs only 250 grams and has a small right and left ventricle. The myocardium is firm with a dark chocolate yellow-brown color throughout. The coronary arteries show minimal atherosclerotic changes, and excessive amount of which of the following substances shown in the figure would most likely be found in the myocardial fibers of the heart. Yep, all of you guys, mashallah, you guys all got it right. So the answer is D. This question, like as I told you, we just collected any question that we felt might be relevant to you. So it's a simple recall question. As long as you recognize the picture, you should be good to go. And so that being said, this is another slide for where you can find it. It's basically a part of atrophy. So whenever there's atrophy in certain areas, such as the heart, for example, or seminal vesicles, you might find this lipofuscins.
Question 4. A 59-year-old woman smoker complains of intermittent blood in her urine. Urinalysis confirms 4 positive hematuria. A CBC reveals increased red cell mass. CT scan demonstrates renal mass. CT guided biopsy displays renal cell carcinoma. Which of the following cellular adaptations in the bone marrow best explains the increased hematocrit in this patient? Got 1C, 1B, or
C.
answers? Mm. Okay. Okay, we can reveal the answer.
Right.
Hyperplasia. Okay, whoever answered C, good job. Now, I get why some people would be confused with dysplasia because it has something to do with cancer and carcinoma, but what we're concerned with here is the hematocrit, the increase. Yeah, exactly. So we have an increase in red blood cells. So can you move to the next slide? So for hyperplasia, we have physiologic hyperplasia and pathologic hyperplasia. Now for the pathologic, it could be to increase in growth hormones or increase in, for example, in this case, we have erythropoietin. So erythropoietin is released from cells in the kidneys. So in case of renal carcinoma, we have increase in those cells. So we have increase or excess erythropoietin, and this would lead to red blood cell hyperplasia, which means we have increased red blood cells, hence the increased hematocrit in this case. Is that clear? Tamam. Next question.
Right, so as Shahd just mentioned to you, there's 2 different types of hyperplasia. And so here's like another question to like show you how they could ask you about different concepts in hyperplasia. So for example, we can see here that a 16-year-old boy sustained blunt trauma to his abdomen when he struck a bridge abutment at high speed while driving. You can skip this, just go to the last part. A CT scan of the abdomen shows that the liver has nearly regained its size before the injury. So with that being said, yeah, so basically it's another example of the different concepts that Chad explained earlier, which is basically that certain organs in the body, once you do a transplant, such as this liver, when it gets transplanted, they can regenerate themselves. So that's why whenever they do a liver transplant, they would only give you like a small part of it and not like an entire liver, because the liver can then regenerate itself inside your body. And this is like an example of the physiological hyperplasia or compensatory hyperplasia. All right, now let's go to the actual question number 5. So would anyone like to read the question and give us an answer instead of us reading it for you guys?
A 90-year-old male with severe dementia has been bedridden for 5 years. Physical examination reveals no ulcers on his back, buttocks, or lower extremities. However, his upper and lower extremities are reduced in circumference. The lower extremities more so than upper extremities, with apparent significant loss of muscle mass. Which of the following combinations of molecular mediators is most responsible for the decreased size of skeletal muscle? Atrophy. D.
P53 bags. Right, fair enough. What else? Any other choices? Any suggestions in the chat? We got 1D and 1E.
I have a few E's.
All right, so Khalid, you said that what happens here is atrophy, right? And we got atrophy because it says that there is loss of muscle mass, so which is basically an indication of atrophy. Now, from your slides, the main mechanism of atrophy that is explained is basically the ubiquitin proteasomes. Now, you guys know what ubiquitin is, خلاص. By this point, you should all, like, immediately, whenever you see ubiquitin, what is it going to be associated with? Protein degradation. All right, so whenever you see ubiquitin, it's protein degradation. And basically, it's the main mechanism of degradation that happens whenever you have atrophy. So yeah, so for the ones that said E, good job. And basically, guys, so this is basically for the first lecture. It's all simple questions and straightforward. If you just understand like the differences and the small differences between them, you guys should be good to go. And inshallah, like, should be the hardest, difficult, or like the most difficult concepts that they could get you. All right, so let's go to the next lecture. Any questions before we go to the next lecture?
I just want to add something for those who picked D, P53 and the bags, those are associated with apoptosis. So that's for irreversible cell injury and which leads to cell death. So in this case, we have atrophy. Atrophy is for the ubiquitin proteasome. P53 and bags is for apoptosis. Okay, now we can move on.
Yep. So as Shahd said, it's like apoptosis is like mostly going to be associated with like death, but here like it could be cell death, but mainly it's going to be like degradation of the proteins by the ubiquitin and the proteasomes, and that's why the muscle is still there. Like the muscles are alive, but the muscles are just getting smaller. So like this is the main thing that happens in atrophy compared to apoptosis.
Can move on to the second lecture. A 30-year-old man with AIDS dementia complex develops acute pneumonia and dies of respiratory insufficiency. At autopsy, many central nervous system neurons that display hydropic changes, degradation. This manifestation of sublethal neuronal injury was most likely mediated by impairment of which of the following cellular processes? We try to look at a couple of these.
Most of you are seeing these, so show the answer choice.
Okay, good job. The answer is plasma membrane sodium transport. And according to your slides, can you show the slide? You can see hydropic changes are related to cell swelling. So in this case, what happens is due to the decreased ATP production, we have, okay, so due to a decrease in ATP production, we have an abnormal or a problem with the transport of ions. So for example, we have the NAK ATPase channel. So this would move sodium into the cell and potassium out of the cell and so on. And the water will follow this ion movement. So if you don't have ATP in the cell due to the cell injury, this would affect the channel. So the ion movement would be affected and the water movement also will be affected. So this would cause cell swelling, also known as hydropic changes. On the next slide, you can see the image. Yes, here you can see cell swelling, which is the hydropic changes. Now, this happens due to the abnormality in ion transport because of the channels, and this would affect the water movement again, causing these hydropic changes. Is that clear now?
So adding on what Shahd said, I would like to add, so basically, you know how whenever we have a cell injury, there's two types. It's either reversible or irreversible. And the difference between them is that whenever you get membrane damage, whenever the membrane of the cell is damaged, this is the indicator of an irreversible injury. All right, so whenever the membrane of the cell is intact, whatever happens inside the cell is reversible. All right, so the hallmark for an irreversible injury is membrane damage. And whenever you get the membrane damaged, what happens? The stuff that are inside the cell will start leaking out. So for example, if someone has a heart attack, the stuff or the proteins that are inside the heart are going to go out. And this is how we know that he had a heart attack, because the cells died. And if they died, means their membrane got damaged. Now for this question, it's talking about a reversible injury. And the hallmark for a reversible injury is cellular swelling. The cell gets larger, however, there is no damage to the membrane. The cell is only larger. And all the effects, every single effect that happens in a reversible injury is always going to be linked to the plasma membrane sodium ATPase transporter. When the sodium ATPase transporter is broken, whatever happens, like when the sodium ATPase transporter is broken due to the loss of ATP production, what happens is that the sodium will start building up inside the cell, because normally the 3 sodium is going to be removed outside. And so as a result, the 3 sodium are going to stay inside the cell. And when the sodium stays inside the cell, they will absorb the water inside, and this causes the cell to swell. All right, so next question. A 40-year-old man is pulled from the ocean after a boating accident and resuscitated. 6 hours later, the patient develops acute renal failure. Kidney biopsy reveals evidence of karyorrhexis and karyolysis in renal tubular epithelial cells. Which of the following events preceded these pathological changes? All right, before we answer these questions, do you guys know what karyorrhexis and karyolysis means? Can someone unmute their mic and explain what they are?
Can I?
Go ahead.
These are the changes that happen to the nucleus. So we start by pycnosis, which is the chromatins will condense, and then the doctor called it the naqtiya, so it looks like a dot. And then you have the karyorrhexis, which is the fragmentation of the nucleus, and then karyolysis, which is the damage to the nucleus.
All right, so what do you think the answer is in that case?
It decreases the pH, C.
C. All right, so yes, as you guys said, the answer here is decrease in intracellular pH. And basically it's because of the damage that's happening to the nucleus. As you guys said, again, there's no more ATP synthesis and there's going to be damage to the nucleus. And so a decrease in the pH will lead to denaturation of the proteins and the activation of the enzymes. And then the changes are going to start happening. All right, so next question.
Okay. 40-year-old man had undifferentiated carcinoma of the lung. Despite chemotherapy, the man died of widespread metastases. At autopsy, tumor were found in many organs. Histologic examination showed many foci in which the individual tumor cells appeared shrunken and deeply eosinophilic. Their nuclei exhibited condensed aggregates of chromatin under the nuclear membrane. The process affecting these shrunken tumor cells was most likely triggered by the release of which of the following substances into the cytosol? Okay, we got a couple of these. Okay, so it's fine.
Oops.
So the correct answer is B, cytochrome C. Now, can anyone tell me what does cytochrome C activate?
Caspase
9.
Exactly. So we have the formation of the mitochondrial permeability transition channels. This will allow cytochrome C to escape. Now, cytochrome C will activate the intrinsic pathway of apoptosis. In this case, due to the activation of caspase 9, which is an initiation caspase, so this would activate the intrinsic pathway and would lead to apoptosis. Any questions? Can move on.
All right, next question. A 60-year-old man was rushed to the hospital with acute liver failure. He undergoes successful orthotopic liver transplant. However, the transplanted liver doesn't produce much blood for the first 3 days. Poor graft function in this patient is thought to be the result of reperfusion injury. Which of the following substances was the most likely cause of reperfusion injury in the patient's transplanted liver? Nope. So, mashallah, most of you guys got it right. Basically, the answer is E, reactive oxygen species. Now, the basic keyword here is reperfusion injury. Whenever I see a reperfusion injury for myself, I always think of 2 things, oxygen and calcium. Oxygen, which will cause reactive oxygen species and damage, and calcium, which will cause more contraction, which will also lead to more damage. So basically what happened in a reperfusion injury is that the cell has already got injured and it died. However, for example, it's mostly going to be associated with situations when there is a blood loss. So in ischemic damage, this is when you can find reperfusion injury. So if there is ischemia and there's no blood flow, and then you remove this cause of blockage, and then you can have blood flow again, you're going to have these 2 changes and these 2 damage. Oxygen, which causes reactive oxygen species, and calcium, which will cause contraction bands to appear. All right, so let's go to the next question.
Okay, move on to
Okay,
the next
so
section, cell death.
cell death 1. Now, before we go into that, I'll just show you here, this is the slide for the different other components that are going to be associated in reperfusion injury. This is from your slides. You can have leukocytes, you can have the complement systems, you can have reactive oxygen species, you can have calcium, or you can have the compromised defense mechanisms. So yeah, so make sure you're familiar with all of them. Okay. Any questions about the first two lectures? All right, sounds good.
63-year-old man has 2-year history of worsening congestive heart failure. An echocardiogram shows mitral stenosis of the left atrial with left atrial dilation. A thrombus is present in the left atrium. 1 month later, he experiences left flank pain and notes hematuria. Lab testing shows elevated serum AST. Which of the following patterns of tissue injury is most likely to be present? Okay. Have these. تمام. Show the answer. تمام. So, good job. Correct answer is coagulative necrosis. Now, coagulative necrosis is associated with any blockage, so we can move on to the next slide. So here, as you can see, the most common cause is ischemia. So in this case, we have a thrombus. So this would block the blood flow, causing ischemia, and this would lead to coagulative necrosis. Now, what is the difference between coagulative necrosis and liquefactive necrosis on a histology slide? Can anyone tell me? Yes.
In coagulative necrosis, the architecture of the cell is still preserved.
Exactly. Meanwhile, in liquefactive necrosis, you just see it all blended. You can see there's an image coming soon. So, can move on.
All right, next question. The following is a picture of the pancreas and the peripancreatic fat. Which of the following describes the type of necrosis that will occur in the peripancreatic fat? Okay, so we got a B, a C, and a none. So I think the none should try again. Honestly, guys, I'm just gonna mention it right here. So this question we had in our exam, and it gave me PTSD. So this is the way I brought it for you guys. It should be enzymatic fat necrosis C. All right, so the correct answer for this question here is going to be B, coagulative necrosis, because basically, so to explain it, in the pancreas, we have two types of necrosis, right? All right, so I'm gonna ask you guys some questions, and I would like if one of you can unmute and like try to answer with me. So what is the main cause of the necrosis that happens in the pancreas?
The buildup of the pancreatic ducts secretion.
Yes, exactly. So the buildup of the pancreatic enzymes are going to be responsible for the necrosis. You have two types of necrosis. One that occurs inside the pancreas. And what type of necrosis occurs inside the pancreas?
Liquefactive.
Liquefactive necrosis. And the other question, or the other one, which is the question right here, which is what type of necrosis will occur outside the pancreas? The answer is coagulative necrosis. Now, for the ones that said enzymatic fat necrosis, basically enzymatic fat necrosis is the same as coagulative necrosis, or like in the situation of the pancreas, it's the same as coagulative necrosis. Now, when I had the question in the exam, I got confused, same as you guys, and I got the question wrong. Now, if you look at the picture here, you can see like basically the structure isn't really messed up as much. So compared to other liquefactive necrosis, so like this should be an indicator. However, it didn't work for me either. But when I like actually looked into the explanation of it, basically what happens here is that only in the pancreas, right? Only in the pancreas. Whenever this fats are, or like these enzymes are going outside the pancreas, and they will start destroying the fats that are around it, right? So this will create enzymatic fat necrosis. However, there is something that happens in this area, which is referred to as saponification. Wait, let me check if it's in the slide. All right, so it's not in the slide. All right, so what happens is, oh, there it is. Okay, so yeah, we have the process of saponification. Now, what saponification is, it's basically that the fatty acids are combining with the calcium. So the fats that are broken are combining with the calcium, and this creates this saponification. And the saponification is basically going to allow it to hold its shape and hold its structure. So even though it's fat, even though it's enzyme necrosis, even though it's enzymatic necrosis that's happening, and even though that the enzymes are destroying this area, and usually, like most of the time, enzymes are associated with liquefactive necrosis, only in this situation, the saponification will cause it to become coagulative necrosis. And I don't think you will be able to appeal it, because I also tried to appeal it, and I went to Dr. Ovan's office, and it didn't work. So I've just brought you guys this question to traumatize you as well. So yeah. Anyways, if you get this question, what happens inside the pancreas is going to be liquefactive, and what happens outside the pancreas is going to be coagulative necrosis. All right? Okay, next question. Is it clear before we go to the next question? It's mentioned as fat necrosis. Yes, I know. Pathoma is the exact reason why I put it fat necrosis, and this is the exact reason why I went to his office, and it's the exact reason he denied my appeals. I even got it from first aid. He was like, nope, saponification is there, so it's going to become coagulative necrosis. Saponification is going to hold it in its place. So, yeah. Yo, خلاص. If you got this question, you're going to put a saponification, you're going to put a coagulative.
And you better be traumatized now than doing the midterm.
Yo.
Yeah.
All right,
I
let's
have a
go to the
question.
next. Yes, for sure.
If the question was reversed and they asked about not in the prepancreatic fat, in the pancreas itself, will the answer be liquefactive? Or
Yes, most likely. Yep.
Okay.
Because in the pancreas, there's no saponification that's happening, and enzymes are usually associated with liquefactive necrosis.
Okay, thank you.
Now, 22-year-old construction worker sticks himself with a sharp rusty nail. Within 24 hours, the wound has enlarged to become a 1 centimeter sorted drained thick purulent material. This skin wound illustrates which of the following morphological types of necrosis? Okay, this is a simple question. Liquefactive necrosis. Now, liquefactive necrosis is mainly seen in, so the most famous example is in the brain tissue. So any abscess in the brain would be liquefactive necrosis. But in other cases, it can be seen also, which is in bacterial infections. In this case, due to the rusty nail, bacterial infection would cause the collection of the debris and the neutrophils, and this would lead to liquefactive necrosis. This is a direct question, nothing confusing this time. Any questions?
I think most of you already know it, that any type of ischemic injury in any other organ other than the brain will lead to coagulative necrosis, and the brain is going to be liquefactive. I just want to mention it again because it's really high yield, even though I'm pretty sure like most of you already know it. So, yep. And I just want to point out also enzymatic destruction for the previous question. Enzymatic is always liquefactive except in saponification states. All right, so.
Yeah, so we have these two images. Which one is coagulative and which one is liquefactive?
Second one is coagulative.
Yes. So you can see the preservation of the cellular structure. So the right one is the coagulative, while in the liquefactive one, you can see there's loss of architecture and necrosis, which is the liquefactive. Again, in the case of the brain and in bacterial infections. So.
All right, next question. A screening chest radiograph of an asymptomatic 37-year-old man shows a 3 centimeter nodule in the middle lobe of his right lung. The nodule is excised with a pulmonary wedge resection, and sectioning shows a sharply circumscribed mass with a soft white center. The microscopic appearance is shown in the figure. The serum interferon gamma release assay is positive. Which of the following pathological processes most likely occurred in this nodule? I just want to point out, like, as you guys can see, the questions will be very long, like a lot of paragraphs, and then like the main point of the question is just 1 or 2 simple words. So like, don't get overwhelmed with the amount of information that they give you in the question. But yeah, most of you guys got it right. So the answer is gaseous necrosis as well. And what is the key mark that tells you that this is gaseous necrosis?
Granulomas.
Exactly. So the giant cells, which forms a granuloma, is basically the key hallmark for any caseous necrosis. Okay, so this here is the final part summary that we made for you to differentiate between the different types of necrosis that you might get in the questions. So coagulative necrosis, the structure is going to be maintained. It's going to be seen in ischemia of all organs except the brain. Liquefactive necrosis is going to be enzymatic destruction that is going to be seen in brain infarction, bacterial infection, and abscesses, as Shahd explained earlier. And it's going to be seen in pancreatitis if it was inside the pancreas. Now, for caseous necrosis is always associated with granulomas and giant cells. If you see a giant cell, and for those of you that didn't actually see it, it's basically this thing right here. So this is a giant cell. And we refer to this one as the horseshoe giant cell because it looks like a horseshoe. All right, so yeah. So caseous is granulomas, giant cells, and it's seen in two situations, TBs or fungal infections. There are other situations where you can see it, but like these are the main two or the most common two that you will be asked about. And the previous question was probably a TB situation because TB, tuberculosis, affects the lungs. So if you see like a situation of the lungs, diseases, upper lobe, mostly it's going to be a TB and caseous necrosis. Now, other types are the traumatic fat necrosis. So the traumatic fat necrosis due to trauma, which causes liquefactive necrosis and seen in breast mainly. Like if you were to get a question, it's going to be about that. Enzymatic fat necrosis is going to be fat destruction by enzymes, and this is going to be seen in the peripancreatic fat. However, there's a ponification this time, and that's why it's coagulative. And lastly, you got fibrinoid necrosis. Fibrinoid necrosis is going to be associated with blood vessels. Any questions about blood vessels is fibrinoid. And gangrenous necrosis, you got two types. You got the dry gangrene, which is the coagulative, and the key word is mummified. And you got the wet gangrene, which is going to be liquefactive, and the key word is superimposed infection. So what happens usually is that you get a dry gangrene that happens, and so that it gets so messy that there's no more protection in that area with the dry gangrene. As a result, you can easily contract an infection, and the infection will come creating a wet gangrene. So this is why we refer to it as a superimposed. So it is imposed on top of this dry gangrene. All right, with that being said, we reached our first checkpoint. We're just done with Dr. Oban's lecture. Oh no, we still have cell death. Never mind. All right, so for the first few lectures, is it all good? Would you guys like to have a small break? Or should we keep going?
Come
All right, let's keep going then. All right.
Now to cell death 2. Okay. An experiment introduces a knockout gene mutation into a cell line. The frequency of shrunken cells with chromatin clumping and cytoplasmic blebbing is increased compared to the cell line without the mutation. Overall survival of the mutant cell line is reduced. Which of the following genes is most likely to be affected by this mutation? Tamam. You got 1B. The rest? Okay, so most of the answer are between B and E. Okay, so the correct answer would be B in this case, BCL2. Now, basically what's happening here is we made a knockout gene. So we removed one gene, and this led to apoptosis or cell death. Now, what happened here is when we got rid of this gene, the cells started dying. So this gene should be anti-apoptotic. So usually in the normal function, it should prevent apoptosis. Now, when we got rid of this gene, apoptosis started happening. So in this case, you can see the examples. We have bags. We have can you go back?
Also.
So you have bags. You have C-mic, you have FAST, and P53. So usually what we have is C-mic, which is the letter C, is not related to your lectures. This is something related to cancers and tumors. So now we have bags, we have FAST, and P53. These are usually these are usually pro-apoptosis. So they would help with the apoptotic process. Meanwhile, BCL2 is anti-apoptotic. So if we see in the next slide, yes. So you can see in the anti-apoptotic proteins are BCL2 and BCLX. So when we reduce those, or when we get rid of them, apoptosis would start happening, as you can see in the case. Is that clear? Now, usually have balance between them. We have balance between P53 and BCL2, for example. But if one of them would take over, this would either, so for example, in this case, BCL2 is removed. So you have P53 and the others which are pro-apoptotic will take over. So now the cell will start dying. Tamam?
Like, I'd recommend you guys find a way to remember that BCL2 and BCLX is like associated with anti-apoptotic compared to the backs and backs. For me, the way I used to remember is that I'd make BCL similar to BLC. So you know how BLC is a peel question so that you don't die. So BCL is preventing you from dying. So that's what I used to remember. So try to find ways so that you don't confuse yourself in the exam. All right, next question. Which one of the listed statements best describes the mechanism through which pass initiates apoptosis? Most of you are saying E, so
now we have few C's.
C is my bad.
So, okay, it's the correct answer. Good job. So we said FADD would stimulate caspase 9. Now remember in the cytochrome C question, we said cytochrome C would activate which caspase? Yes, exactly. Cytochrome C would activate caspase 9, while the FAST and FAST ligand in this pathway would activate caspase 8. Now, these are both for the apoptosis, but what is the difference between them? Now, for the cytochrome C, this is released when there's the mitochondrial permeability channel. So that was for the intrinsic pathway. There's a problem with the cell itself. Now, now in this case, this is the death receptor pathway, which is extrinsic. So we have caspase 8 and caspase 9 for apoptosis. That case was for intrinsic. This case was for extrinsic, but both are the initiation caspases. Now, in this case, we have the FAST. The FAST ligand will bind to the FAST receptor. This would activate caspase 8 and move on with the executional caspases and so on. And this would activate the cellular apoptosis. But the only difference is that in this case, this is extrinsic. In the cytochrome C, it was intrinsic. Is that clear?
And when it comes to this question, guys, like remember both TNF and fast CD95. Don't only remember one of them, because like he can ask you about TNF in this question. Like this part could be TNF, but it's like not this choice because TNF doesn't inhibit this part. But basically, like he can ask you about TNF, or he can ask you about CD95. Right? So like make sure to remember both of them. Is it clear? Right, then let's go to the next question. In a study of viral hepatitis infection, it is observed that cytotoxic T cells induce death in virally infected hepatocytes. The cytotoxic lymphocytes release perforin to allow the entry. Which of the following substances found in these granules that activate the programmed cell death? Yup, you guys, bunch of C's, 1, 2, 3 C's. I'll give you a second so that for the others to answer. Yeah, most of you are saying C. So in this case, C is the correct answer. And it's just like pure memorization. Perforins and granzymes. Perforins are released by the cytotoxic T cells. And what other cells use the perforins and granzymes? Do you guys know about? There's another type, yes, exactly. Natural killer cells. So both these cells will use perforins. Perforins creates the perforations or the holes, and they go inside. And granzymes is going to destroy the cell. So yeah, it's pretty easy, straightforward question. Now, if you can see here, this picture like is a summary of all these questions that we asked you guys, and this is a very high yield picture that like you really need to remember. So if you had a T lymphocytes that are going to be associating this apoptosis pathway, T cells activate the granzymes, right? And they activate the executioner caspases. There were executioner caspases, I forgot their number, I think 3, 6, and something, but I'm not sure. But you need to remember what the executioner caspases are. There is the receptor ligands, which are FAST and TNF, all right? Both of them, you need to remember both of them that could be activated. There's also going to be the intrinsic pathway through the mitochondria, which is basically the cytochrome C. When the mitochondria is damaged, cytochrome C is coming outside, and who keeps it in check? The BCL or the BLCs. And then if we have an injury, which is radiations or toxins, like whenever someone gets radiation, it will cause DNA damage. And P53 is also another pro-apoptotic factor, right? So make sure to remember the different causes and the different stimulators or the stuff that are going to be activated from this picture, right? Now, that being said, we're done with Dr. Oban's lecture and we can go to Dr. Obrar's lecture. All good, you guys? Any questions? Inshallah, this should be like the highest level of questions they get you. Inshallah, they don't get you anything that's outside of the scope of these concepts. All right, so we can go to the next question right here.
What is the mechanism involved in acute inflammation? This is a direct equal question. Short one A, طلب rest. D. So this is a type of question you wouldn't know that how confusing it would be unless you actually saw the question, because it was stated clearly in the slides. You can move on to the answer. So the correct answer is actually B. So we start with vasodilation, exudation, immigration of cells, and then chemotaxis. Can we move on to the next slide? So this is how it was in your slides. So the mechanism of inflammation starts by vasodilation. As you can see in the image here, the top image, you have the normal vessels. And the image below, you'd see the vasodilation. Vasodilation basically means the blood vessels will expand or dilate. Now, this would allow more blood to flow through those vessels. And now we also have the endothelial cells contracting. Now, when the endothelial cells contract, they would allow an exudate to leave. This exudate would lead to edema, which you can see is in the second point. So we started by dilating the vessels. The endothelial cells start contracting. We will have edema when the exudate leaves the vessels. And then, again, due to the increased permeability of the vessels, we have immigration of cells. So the cells will start leaving. Any cells related to inflammation, and you also have chemotaxis, in which you have some substances released, and they would attract the neutrophils, macrophages, and so on, depending on the type of inflammation. So we start with vasodilation, then exudation and edema, then cells will start to migrate from those vessels, and when the substances or the chemotaxins are released, other cells would migrate into the area of inflammation. Is that clear?
And if you guys take a look at the choices, so like mainly the first thing that would happen that you guys should be aware of is vasodilation, because as Shahd said, like vasodilation allows more blood to flow through, and at the same time vasodilation will cause the blood to flow like at a slower pace, which allows it like more chance for the neutrophils and these cells to go to the border so that they can actually go to the area of damage or the area of infection. So like immediately anything that doesn't start with vasodilation, you can cross it out. So this way we cross out C. Now the next thing that you have is chemotaxis. So what does chemotaxis mean? Chemotaxis is basically when the actual area of damage, when the neutrophils go inside this tissue, right? The neutrophils now are inside the tissue. This area of necrosis or damage or bacterial infection, they will release these factors that will cause the neutrophils to move. However, like as we said, this only happens when the neutrophils are inside the tissue. So that way we can know that chemotaxis should be the last step, because if chemotaxis is occurring, then the neutrophils will go to the tissue and they will start destruction and phagocytosis. So if there is no choice of phagocytosis, this means that chemotaxis is the last choice. And that way we're either going to have to go with A or we're going to have to go with B. And we crossed out C and D. And then the next thing is going to be differentiated between the exudation and the immigration of the cells. Basically, exudation means that, as Shahd said, it's that the fluids that are in the blood, they will leave the blood to go into the tissue, right? So the fluids will leave the blood and go into the tissue. So this happens before the cells can start immigrating more into inside the area of the tissue, right? So what happens? The fluids will first go in because they can pass in more easily compared to the cells, which will need the p-selectins and the integrins and whatever other stuff. So the fluids start to go in first, and then the cells, since they take more time, they start to go in after them. And lastly, the cells will be directed by the chemotaxis. So like instead of just memorizing it, try to understand it. So does this make it clear for you guys?
But how will the cells enter without chemotaxis?
The chemotaxis, like, yeah, go ahead.
Chemokines are needed command for integrins. So there are no integrins without chemokines.
Now, the chemokines, like the other parts of them, and basically they're going to be like recruiting them from outside, but mainly whenever they refer to chemotaxis, they, they mainly want you to understand that chemotaxis is that the movement of the neutrophils inside the tissue to the area of damage. And like for other ones, they refer to them as chemokines, which is like other stuff, I forgot what they were, but like other factors, which will just be responsible for recruiting them. But like whenever they refer to chemotaxis, they mainly want you to think about the moving of the neutrophils inside the area. And like at the same time, these chemokines that are released, like including histamine, these chemokines, they don't only occur after vasodilation. These chemokines are responsible for vasodilation. So like if you wanted to mention that point, then the chemokines should be like the first thing, because the chemokines such as histamines will cause vasodilation, which will then cause the exudation and the emigration. But mainly the chemotaxis is similar to ataxy. So the taxi is basically going or taking you to the area. So they're inside the tissue and the taxi is taking them to the area of damage. So yeah, CXCs and C3XCs. Yeah, so basically these are some examples of the chemokines. So is this question clear for you guys now? Like always, chemotaxis is the movement inside the tissue.
Tamam.
From NHI, chemotaxis is the cell movement of cells toward the gradients of solubilized attractants, whereas chemokines is random cell movement in the absence of a chemoattractant. So yeah, basically chemotaxis is moving the cells towards the area of this attractant or towards the area of damage or bacterial infection that is causing them to release these chemotaxins that are going to be absorbing it. Okay, let's go to the next question. A 6-year-old child has a history of recurrent infections with pyogenic bacteria, including Staph aureus and Strep pneumo. The infections are accompanied by a neutrophilic leukocytosis. Microscopic examination of the specimen obtained from an area shows microbial organisms, but very few neutrophils. Analysis of the neutrophil function shows a defect in rolling. The child's increased susceptibility is most likely caused by a defect in which of the following? A. Yep, most of you guys, all you said A, which is the correct answer. So basically what happens here, since the issue is in rolling, so the problem is in selectins. And you can have this picture right here, which basically shows you exactly what happens. There is the neutrophils. There's going to be like cytokines or whatever. So see here, cytokines are the ones that are going to be attracting these neutrophils. They're going to be causing the vasodilation. They will cause everything. So neutrophils now can move closer to this area. So the selectins are going to be responsible for allowing the rolling process. And we have other questions for other parts. So I'm not going to go over them, but mainly selectins are going to be for rolling. So yeah, good job, you guys.
A 5-year-old child has a history of recurrent bacterial infections, including pneumonia and otitis media. Analysis of leukocytes collected from the peripheral blood shows a deficiency in myeloperoxidase. Which of the following is the most likely cause of the child's increased susceptibility to infection? We got a few C's. Okay, again, good job. We have 1 E. Okay. So the correct answer would be failure to produce hydroxy halide radicals. Now let's go to the pathway. Let's see the pathway. So you can see it starts with the phagocyte oxidase. Now what happens here is, first you should know that this is oxygen dependent. So we have the phagocyte oxidase starting with this. Now from it's an oxidase, so it will oxidize NADPH. Now we'll be left. It will convert oxygen to an oxide radical. So this radical, now this will give us the pathway to form the active oxygen species. Where is myeloperoxidase involved? Myeloperoxidase is involved in the conversion of hydrogen peroxide to the hypochlorous acid. And so this is the reactive oxygen species involved. Now, if you go back to the options, can you go back? Okay, so you can see here for whoever answered E, option E is failure to produce hydrogen peroxide. Now, you can see that monoperoxidase will convert this hydrogen peroxide to the oxygen species we need. So option E is wrong in this case. So you can see yes, can you go back? So here we said we have deficiency in monoperoxidase, so you have failure to produce hydroxy halide radicals. Now, for the other options, we have defective neutrophil degranulation, but this is not involved with with degranulation. Production of prostaglandins. Prostaglandins is involved in the COX pathway and the production of the prostacyclin, prostaglandin, and so on. So it's not related to the monoperoxidase and the reactive oxygen species. C is the correct answer. Now, a decreased oxygen consumption after phagocytosis. Again, we saw that that in this case, no, we need oxygen consumption to produce those reactive oxygen species. So D would be wrong. Again, we explained why E is wrong. So correct option would be C. Is it clear now? So.
All right, so also like guys, be aware of the other reactive oxygen species that are formed, such as iron, how it helps form this hydroxyl. The nitric oxide formed from arginine, through the nitric oxide synthase, it helps form this NO thingy. So yeah, like be aware of the three different enzymes that are responsible or like that are taking part of this process. Like even phagocyte oxidase is really, really important to remember that phagocyte oxidase is responsible for this conversion because like remember we had a question about it. So you need to be sure that you're really good with differentiating their different functions. And lastly, that it is an oxygen dependent pathway. Okay, so next question. In an experiment, bacteria are introduced into perfused tissue preparation. Leukocytes leave the vasculature and they will migrate to the site of bacterial inoculation. The movement of these leukocytes is most likely mediated by which of the following substances? B is بس بس أفيل. There's a D.
Yes, we working.
Okay, so the correct answer for this question is B. Complements can be chemokines too. Khalid, that's a fair point. However, which complement is a chemokine? Is it complement 3A or is there another complement? Yes, good job, Clay. So complement 5A is the one that, yeah, so correct you guys. 5A is the one that's a chemokine. However, 3A is not, so this is why you cross out C, and that's why you don't appeal this question. And histamine is a vasodilator. So this one here is talking about movement and not dilation. So this is why D is wrong. Prostaglandins are going to be like responsible in permeabilities and pain and other stuff. They're not really responsible for it's not responsible for moving. So you don't do E. Bradykinin is similar to prostaglandins. It's not really responsible in movement. So basically the answer here left is chemokines. And basically cytokines used for chemotaxis are chemokines. And these are the ones that you need to remember, right? So 1 is going to be bacteria. Okay, bacteria is. 2 is going to be complement, only 5A. 3 is going to be interleukin 8. 4 is going to be the LTB4, leukotrienes B4, right? Not any other leukotrienes, only B4. And 5 is going to be the neutrophil products. Both 5A and 3A وحتى 4A يا شباب. No, it's not 5A and 3A. Wait. I do have a slide that shows you the difference for the 3 different complements at the end of this lecture. So you'll see the difference in their functions. I did mention it at the end of the lecture. So, but for now, I need you to remember that the chemotaxis cytokines are B4, interleukin 8, C complement 5A, and bacterial products or the neutrophil products. Okay? So, next question.
A 4-year-old girl has had numerous infections with Staph aureus since infancy. Genetic testing shows a defect leading to lack of beta-2 integrins, CD18 production. Which of the following abnormalities of neutrophil function is most likely responsible for these clinical symptoms? D. So everyone's saying D. طيب هلا
Okay.
this has part 1 and part 2. So we'll be solving part 1 and part 2 and then explaining both. So which of the following diseases does the child have? Which disease is involved with the integrin production? D.
Bunch of B's, bunch of D's.
تمام. We can move on to
Okay,
the
so
answers.
the first question you guys said it's D, right? And the second question you said B.
Yeah.
Okay, so the answer is for the first one.
Yeah, for the first one, you guys got correct. Inadequate adhesion on cytokine activated endothelium. Now, can anyone tell me integrin would bind to which components?
ICAM.
Yes, exactly. So, meanwhile, the selectins would bind to what? Yes, exactly. The Cellular Lewis. So, selectins are with Cellular Lewis, while integrins are with the ICAM. So, in this case, integrins would bind to the ICAM in the cytokine activated endothelium, and this would allow the neutrophils after they finish rolling to attach and go into the area. So the correct answer in this case is inadequate adhesion. So is L-selectin same as Cellular Lewis? No. So you have one part on the neutrophil and one part on the endothelium. They would bind to each other, which would allow the rolling and the adhesion. Now, in case of rolling, you have the L-selectin and the P-selectin, which would bind to Cellular Lewis. Now, they are not the same, but they bind together. Now, for the integrins case, you have the integrins on the neutrophil binding to the ICAM on the endothelium. Is that clear? تمام.
The next question is A. I changed my answer. Oh, yes, it's E selectin. Oops. So yeah, so P and D selectin are on the neutrophils, while the Cellular Lewis are going to be on the endothelium. Oh wait, I think it's the opposite. Never mind,
Yeah,
it's the opposite. Yeah,
opposite.
it's the opposite. So E and P are in the endothelium, and the Cellular Lewis are in the neutrophils. Okay, so the next question, we had someone change their answer to A,
Yes.
which you got it right last second.
So it's leukocyte adhesion deficiency type 1. Now, can anyone from those who answered type 2 tell me what is type 2 associated with? So we have leukocyte adhesion type 1, and you have type 2. Exactly, yes. So in type 2, this is involved with the Cellular Lewis and so type 2 is involved to Cellular Lewis and so on, while in type 1, you have problem with the integrins. So in this case, we said problem is with integrins, so the binding to the cytokine activated endothelium, and then the problem is leukocyte adhesion deficiency type 1. You can go to the next slide. So you can see here, you can see the ICAM binding to the integrins after the neutrophil finished rolling. So after the adhesion, they would go inside the tissue to cause the inflammation. And as you can see below, leukocyte adhesion deficiency type 1. So there's a defect in the biosynthesis or the beta-2 chain shared by the LFA1 and MAC1 integrins. Meanwhile, we said in type 2, we have the Cellular Lewis and so on. Tamam.
Is it clear, guys? Both questions, part 1 and part 2?
I guess we can move on.
Okay, so question 22. A 6-year-old boy falls off his bicycle while in the driveway of his house. His mother witnessed him fall and sees that he strikes his knee against the ground but doesn't hit his head. She feels that he's fine and returns to work. About 20 minutes later, at the house, she can see the skin on his knee where he hit the ground is intact but red. The red discoloration of the skin is not a cause of the following mediators which played the largest role in producing the visible change in the skin. Right, so aside from that, like forget the choices for now. What physiological process is going to be responsible for the red skin?
Vasodilation.
Yep. All right. خلاص, now you can go back to answering your choices. CR7. Yes. خلاص, correct. CR7 is the answer. Histamine. So as we said earlier, like histamine is a potent vasodilator. So this is why the answer here is C. Now ICAMs and PECAMs are not really associated with vasodilation. They're more about the neutrophil pathway. Thromboxane A2 is responsible for platelet aggregation and stuff. So it's not really the choice. P-selectin and E-selectin are going to be also in the neutrophil pathway movement. So this is why the answer is C. All right, now that we're done with this lecture, I brought you guys, like Shahd and I brought a summary for the different signs of acute inflammation and what exactly are the mediators for them. So you must know these signs, rubor and calor. Rubor is for the red color, which is R and R, and calor is for the warmth. Now, mainly they are going to be due to vasodilation, which increases the blood flow. Now, what mediators are responsible for it? Histamines, bradykinin, and prostaglandins, all right? We can see them from these choices right here. Vasodilation command, nitric oxide. Yes, nitric oxide is responsible also for vasodilation, but like, I didn't put it in this lecture. I put it like in the other lecture for chemokines. However, nitric oxide is also responsible for it. Yep. The next one is the tumor or the swelling. Now, tumor or swelling is due to build-up of fluid underneath. And so if you need to build up fluid, you need more permeability. And what are the responsible mediators? Bradykinin, histamines, and leukotrienes. And then you also got the tissue damage, right? And pain, which is dollar. The way I remember pain and dollar is a little funny, but basically dollar is like dollars and money, and I'm broke, so it's painful. So this is how you remember it. That's for me, that works for me. So yeah, but basically PGE2, and PGE2 is very, very important. PGE2 is responsible for fever. PGE2 is responsible for pain. PGE2 is like the coolest out of the prostaglandins. So like try to remember it. And then you also got bradykinins here. And lastly, for fever, you got interleukin-1, tumor necrotic factors, which are going to be activating the COX pathway, which is responsible for creating prostaglandins, and the hypothalamus. Now, why exactly is it the hypothalamus? Because hypothalamus is part of the brain that is responsible for mediating the homeostasis, the fever, the temperature, and this stuff. So if you have more prostaglandins of PGE2 in the brain, the body or the entire core body temperature is going to be increased because PGE2 causes fever in the brain, right? So these are your main signs and mediator, and just add nitric oxide to the vasodilation part at the start. Okay, so now we can go to the next question.
An immunologist studying the process of leukocyte recruitment in acute inflammation wishes to block the process of transmigration of neutrophils across the endothelial wall. A monoclonal antibody against which of the following adhesion molecules would inhibit diapedesis without interfering with rolling or margination? I know got a few E's. Yes, so we already explained this concept. So, tamam. Yes. So we said rolling and margination. Okay, quick review. Which one is associated with rolling?
P and E are selectins with sideline Lewis.
Yes, exactly. Selectins with sideline Lewis would be involved in the rolling. Margination.
The integrins with ICAMP and VCAMP.
Exactly. So this way we eliminated A and B and then C and D. So we're left with E. So even if you don't know what PCAM does, we eliminated all the other options. So we're left with E.
Just a small pointer is that like integrins and dicams are not margination exactly. Yes. So margination is different than adhesion. Margination is the first step, which is basically the neutrophils going from the center of the blood vessel towards the endothelium. And then you're going to have the rolling, and then you're going to have adhesion. So like integrins and ICAMs are for adhesion, and the P-selectin and D-selectin are for rolling, and the margination is the first thing. So margination, then rolling, and then adhesion. And lastly, you got the diapedesis, right? So, yep. Anyways, good job, you guys. Here's another picture, just explaining it again. basically you can see right here, PE CAMs, CD31 at the last step. So first T is margination, and then you got the rolling around, and then you got adhesion, and then you got the diapetesis. Okay. So that being said, here's a final summary for this lecture and what are the different pathways that will occur. So basically you got the mediators responsible for inside the vessel, which is basically the start. So the first thing, you want to recruit them, attract them, and marginate them, which is basically move them closer to the endothelium. And first thing that happens is vasodilation, so that you can slow them down and you can have more flowing through. And then you have the chemokines. The chemokines are going to be basically recruiting them or recruiting neutrophils. Next step is going to be rolling. And as you guys said, basically rolling, I usually like try to associate it with speed bumps. And whenever you approach a speed bump, you don't really stop, but you just slow down. So rolling is basically slowing down, and the S in speed bumps is going to be associated or slowing down or speed or slow, like whatever S's, they're all associated with selectants. So you got two selectants, the P and the E selectants, which are going to be found on the endothelium. All right, but they keep rolling. Now they selectants start with an S, so they bind to an S. So Lewis X, which are going to be found on the neutrophils, is what they're going to be binding to. And the disease that occurs in this situation is the type 2. And how I remember it is that you see there's two L's, so this is why this is type 2. So type 2 is associated with the two L's of the cellular, and this is basically going to be part of rolling. Now the next part or the next step is going to be adhesion, where you basically stop or come to a complete stop and you're adhering on the endothelium wall. And this is done through ICAMs and VCAM, right? Which are binding on the integrins. And how I remember it is that the ICAM has the eye of integrins, and basically it's integrating itself into the endothelium wall, which is no longer moving. So this is what I used to remember it for myself. And yep, basically integrating themselves. And the disease that you can have here is going to be type 1 deficiency. And the way I remember type 1 is that you see the 1, it looks like an eye. So 1 and I is going to be this deficiency type 1. Now for the next part, which is going to be inside the tissue, we said the first thing that happens inside the tissue, of course, we got the diapetesis here, but I didn't mention it. So step 4 is diapetesis, which is going to be done by the PE CAMs. And then inside the tissue, you have the chemotaxis. 2 looks like an S. All right, or you can do that. So Khalid just said another way to remember it, that the 2 looks like an S. So like try to find your own ways to remember it, or like use methods so that you don't get confused in the exam, and I don't want you like to guys think that was it this or this. I studied both of them and I'm very confused. Like try to get confused now and find the way so that immediately whenever you see it, you can eliminate one of them and go for the other choice. All right, so chemotaxis, as we said, remember chemotaxis is anything that's going to be taxi moving them. So you got leukotriene B4, C5a, interleukin 8, degradation products. Then phagocytosis, again, opsonins are going to be helping us. What are the two opsonins that are going to be enhancing? IgG and C3b. So Khalid, you mentioned like the complements. So C3b is going to be for opsonization, while C5a is going to be for chemotaxis. And I do have a slide later on that will summarize them. So like before now, just remember that C3b is opsonization. All right, then you got phagosomes and phagolysosomes. So phagolysosome is damaged in Shiryak-Higashi syndrome, which is dysfunctional phagolysosome. And then the last step is going to be destruction. So this process, remember the process that Shahd was explaining to you earlier, which is basically the oxygen-dependent pathway. So for oxygen, first thing that you want to do is you want to create the oxygen-free radical. This is an O2 minus, okay? So this is the oxygen-free radical. The way to create it is using a phagocyte oxidase. And how I remember it is the phagocyte oxidase is the same as a P or NADPH oxidase. Okay, so like they can ask you in the exam either an NADPH or a phagocyte oxidase. So both of them are going to be for the first step. Now the O2 free radical is converted to hydrogen peroxide using superoxide dismutase. Now this enzyme is not mentioned in your lecture. However, I do recommend you guys knowing it because like it is important. So superoxide dismutase is for the next step. And then the last step, which is creating the HOCl, is done by the myeloperoxidase. And the other pathway, which was this oxygen dependent, the independent one is just enzymes of the phagolysosome destroying it. So with that being said, you can have a deficiency in the oxidase phagocyte, which is this one, or you can have a deficiency in the myeloperoxidase, which could lead to problems. And lastly is going to be resolution, which is basically the neutrophils. If they finished up you guys didn't take healing and recovery, so like I don't really expect you to know it, so I'm just going to mention it because it helps you now. Basically, resolution is that the neutrophils are going to be dying. if they finished up their work, they killed up the bacteria, they're no longer necessary, they no longer need them. So what happens is that they will die, and then the macrophages will be attracted again in the same old pathway of chemotaxis, chemokines, and the same thing that we explained all this way here. You're going to have the macrophages come back, and macrophages will clean up the area. Neutrophils pick up the destructed area. Anything that's been destroyed, macrophages are picking it up. So basically, this is the entire lecture summarized for you guys. And if I was a little too fast, I will send you the slides after, so like you guys can see them now. This is basically the 3 questions that we discussed earlier. Any questions, you guys? All right, sounds good. Okay. So let's go to, now we have another checkpoint. Would you guys like to take a small 5-minute break, or should we keep going? We only have, we have 3 lectures. We have the morphology, we have the chemokines thingy, and then we have the chronic inflammation. Okay, let's keep going then.
Yeah.
Okay, so the next lecture is the chemical mediators. So, Chad, do you want to go in with the first question?
Yeah. 25-year-old woman presents with a 2-week history of febrile illness and chest pain. She has an erythematous maculofacial rash and tender joints, particularly in her left wrist and elbow. CBC showed mild anemia and thrombocytopenia. Corticosteroids are prescribed for the patient. This medication induces the synthesis of an inhibitor of which of the following enzymes in inflammatory cells? And you guys saw the answer?
No.
I want someone to explain for me.
With steroids, they inhibit the first step in arachidonic acid metabolism for phospholipase.
طيب هلا we have in the yes, can we get to the slide? So this is the arachidonic acid metabolism pathway, starting obviously from the phospholipids and the arachidonic acid. So the phospholipases are at the first step. So this would be involved in both the cyclooxygenase pathway and the lipooxygenase pathway. So the steroids would inhibit the very first step, which is phospholipase A2. Now in the options we had another phospholipase, which is phospholipase C. Now this is involved in the cell signaling pathway, which is not involved in this step. So here we have phospholipase A2. Now after arachidonic acid, we have 2 pathways, either the cyclooxygenase or the lipoxygenase pathway. Cyclooxygenase would give us the prostaglandins, the thromboxane, and prostacyclins. And while the lipoxygenase pathway will give us the leukotrienes, leukotriene B4, C, D, and E. Now for the thromboxane and for the prostaglandin pathway and the prostacyclin, as you can see, each one would be involved with the different steps. But we can inhibit the cyclooxygenase with a specific drug, for example. Yes. So in this case, we have aspirin. So aspirin would inhibit the cyclooxygenase. Now we have COX-1 and COX-2. Can anyone tell me the difference between COX-1 and COX-2?
COX-1 has something to do with blood clotting. صح?
Yes, okay, so as Qusay said. Yes, exactly. Okay, so we have a COX-1 and COX-2. COX-1 is general, so it's not secreted at specific situation, while COX-2 is specific for inflammation. Now, yes, I'm assuming you took this, right? تمام. So basically, aspirin would inhibit the COX enzymes, and this would stop the whole pathway, the prostacyclin, thromboxane, prostaglandin. While for the lipoxygenase, you have the leukotrienes. Now, leukotrienes would be involved with the bronchospasm, for example, leukotrienes C, D, and E. We have the bronchospasm. So, in which cases would this be significant? Does anyone know?
People with asthma or something.
Exactly. So the leukotrienes would cause bronchospasm. So this would exacerbate asthma, for example. Whenever they release, they would cause the narrowing or the constriction of the bronchus, and this would exacerbate the asthma. In this question, they only mentioned steroids. So from the whole case, you just want this one keyword, which is steroids. Corticosteroids would inhibit the whole pathway by inhibiting phospholipase A2. Is that clear?
Don't worry about the parts of the COX-1 and COX-2 or corticosteroids. Like, inshallah, yeah, they won't ask you about steroids. If they were to ask you, yeah, inshallah, the max they will ask you is about COX-1 and COX-2, which is going to be for cyclooxygen, for prostaglandins. Now, I do want to add one thing, is that if you do, like if a patient comes to you and then you give them aspirin, which inhibits cyclooxygenase, what happens is that since you can no longer go down through this pathway and you already created your arachidonic acid, instead of going here, since you can't go there anyway, all of it is going to start going down this pathway. So you're going to have a lot of leukotrienes being created and no prostaglandins since you inhibited them. So, okay, so if you give them an aspirin or like whatever NSAID that will inhibit the COX pathway, you're going to have an increase in the leukotrienes, okay? And one last thing, which is not really part of this slide here, however, do really keep in mind and remember the functions of the leukotrienes C, D, and D, leukotriene B4, and the lipoxins, especially that lipoxins are responsible for inhibiting inflammation. So like these are important cytokines to remember. And PGE2 is responsible for pain, fever, and the different other stuff, right? Now, is it clear? Any questions? We do apologize if it's a little too much in this one question. So inshallah, if you guys understood, then you should be good to go. Okay, alhamdulillah. All right, next question. A 45-year-old woman with an autoimmune hemolytic anemia presents with increasing fatigue. Which of the following mediators of inflammation is responsible for antibody-mediated hemolysis in this patient? Or we can see some C's in chat. Okay, so the correct answer here is C. So as you guys said, the answer here is C. So basically, complement proteins are going to be responsible for this process. All right, so basically you have different parts of complements, right? So the different complements, each of them are going to have a different function. So for example, they can be responsible for creating the membrane attack complex, and in the membrane attack complex, they're going to be, part of the hemolytic anemia that's going to be occurring. Or you can have them being part of phagocytosis, and this phagocytosis, which also sometimes is also going to be responsible in other types of diseases where you can have like phagocytosis in macrophages of the spleen. So this would lead to destruction of the blood vessels. And you can also have the inflammation. So basically, you guys got this. Complement proteins are responsible for the autoimmune hemolytic anemia. All right. And it's like, this is not part of your lectures, but since we just finished heme, I just want to mention it. Basically, what happens is that, the blood or the red blood cells are inside the blood vessel, and where else you would find the complements as well, they are going to be inside the blood vessels. So usually the red blood cells will have some type of defense mechanism that will prevent them from being destroyed by the complement proteins. However, in the situation of whenever there's an autoimmune hemolytic anemia, then this defense mechanism of the red blood cells, or like the different type of processes on top of the red blood cells, they will no longer be efficient, and that way they can no longer protect themselves from the complement proteins, and as a result the complement proteins will start destroying the red blood cells. And this is why it's autoimmune hemolytic anemia, because the complement are destroying the red blood cells. What does kallikrein do? I forgot. Kallikrein, I think it's associated with bradykinin, if I'm not mistaken. Yeah, so
it's fibrinolytic command. It breaks down fibrin clots
mm.
by activating
So,
plasminogen.
all right, so yeah, that's your answer right there. So kallikreins are bradykinins and fibrinolytic. All right, so is this question clear? You guys got it right, mashallah. So let's go to the next part. Okay.
In an experiment, peripheral blood T lymphocytes are collected and placed in a medium that preserves their function. The lymphocytes are activated by contact with antigen and incubated for several hours. The supernatant fluid is collected and is found to contain a substance that is a major stimulator of monocyte and macrophages. Which of the following substances is most likely to stimulate these cells? Okay, so most of you, everyone got correct. This is an easy question, which is the interferon gamma. تمام. We can go to the next slide. So you can see here, next slide. تمام. Yes.
خلاص?
So
The question?
this the explanation, yes.
Okay.
For you. So we have the activation of macrophages. Activation of macrophages is by the interferon gamma. So you can see in the diagram, we have the T cells. They produce the interferon gamma, which binds to the macrophages, activating them so they can produce other substances. And then this would lead to inflammation. So this is a direct recall question. There's nothing confusing about it, I hope. So yeah, T lymphocytes and the natural killer cells would produce this interferon gamma, which would activate the macrophages and the monocytes.
Right.
Does anyone have a problem with this?
I have a follow-up question for you guys. What type of T lymphocyte is responsible for releasing the interferon gamma? Helper cells, type 1 or type 2? It's kind of immunology question. You should know the types. There's like type 1, type 2, type 17, I think, which is responsible for healing. But yeah, you should know the different types and what each different type releases. So I guess you need to revise that. But like good to know now. It's like, does anyone know what type of T helper cell is it? I'm sorry to add more stuff to you guys. But at least you know now. Okay, so Qusay said T helper 1, which is the right answer. So basically, it is T helper cell type 1 that is responsible for releasing the interferon gamma. Now, the pathway of the macrophage activation is very, very, very high yield, and we do have a picture later on to summarize the pathway. So I do highly recommend you guys like revise the exact pathway for the activation of macrophages. All right, next questions. Which of the listed cytokines is secreted by macrophages and functions as a major mediator of acute inflammation by stimulating the acute phase reactions such as fever production along with increasing vascular permeability and stimulating fibroblasts? Right, we got one answer so far. Give you guys a couple seconds so that the rest of you can answer.
I think everyone's answering A.
Yep. All right. So you guys are right. So the answer here is interleukin A, interleukin 1 immune, which is also like kind of a simple recall, straightforward question. Fever is going to be associated with interleukin 1, tumor necrotic factor. There's another thing that's also going to be associated with fever. Does anyone want to mention it? We did mention it before.
Prostaglandin.
Yep. Which type of prostaglandin? E2. Correct. So prostaglandin E2, along with interleukin 1s and tumor necrotic factors, are going to be responsible for fever. Okay. So let's go to the next question.
Oh, I think we only have 3 questions left, so almost done. 35-year-old woman takes acetyl salicylic acid, which is aspirin for arthritis. Although her joint pain is reduced with this therapy, the inflammatory process continues. Aspirin therapy alleviates her pain mainly through reduction in the synthesis of which of the following mediators? Yes, we explained this before, so. Yes,
Yeah,
so
we just
aspirin
posed the
is.
question 1 second ago.
Yeah. So aspirin is involved in the prostaglandin pathway. So the correct answer, as you guys said, VE.
Yep.
So, yeah, I think we explained this before. the cyclooxygenase pathway, which produces the prostaglandins, prostacyclins, and so on. So this would be inhibited by any COX-1, COX-2 inhibitors, like aspirin. So I don't think there's much to say here.
All right, next question then. A pathologist is examining a slide of the appendix and the mucosa, submucosa, and the muscularis. There are numerous cells with abundant cytoplasm and multi-lobe nuclei, with the lobes joined by a very thin bridges of the following mediators, which was most responsible for attracting these cells to the site. Here we have 2 A's so far. Which was most responsible for attracting these cells to the site? I got another A. All right, so last 10 seconds for anyone else to try to answer.
More A's.
Yep. So the correct answer here is, so the correct answer is electron B4, which is A, and we mentioned that earlier. So basically, like, we have a bunch of chemotaxis or the chemokines that are going to be responsible for attracting the cells to the site, and electron B4 was one of them. Can you guys mention in chat like the other ones, so that you mention it now so that you can remember it more? We said electron B4 was one of them. Complement 5A, interleukin 8, and last one, TNF, ILA, bacterial things, yeah, so bacterial degradation products. However, TNF, I'm not sure about TNF. I don't think TNF is right. I think like TNF and LPS aren't really like responsible for chemotaxis. Oh yeah, never mind it. They might be part of the bacteria. So yeah, LPS might be. But TNF, I'm not sure about TNF. I don't think it is one of them. But yeah, so anyways, though, we're done with the lecture. Now you guys can see the summary and you guys can revise them all together. So first of all, I put up this slide for you guys so that we can go over basically like the vasodilation, permeability, pain, and fever. So now that we know like these different factors and how will they be responsible for the basically the acute inflammation, let's look at their different functions and let's basically mention the ones for different functions. So first of all, we have vasodilation. We said vasodilation is for the red color, and vasodilation is going to be also for the warmth. And what are the mediators? Histamines, bradykinins, prostaglandins, and nitric oxide. The next one is permeability. Permeability is mediated by bradykinins, histamines, leukotrienes, and tissue damage, right? So basically, these are the ones responsible for this. Next one is going to be the pain. So pain is always PGE2 and bradykinins. Okay, so bradykinins and pain and PGE2 are responsible for pain. Now for fever, we got PGE2 again, interleukin 1, and tumor necrotic factor. So interleukin 1 and tumor necrotic factor, we said these are the ones that are going to be stimulating the hypothalamus. And then the prostaglandin E2 is going to be responsible for what? The prostaglandin E2 is responsible for increasing the temperature of the hypothalamus. And then for the chemotaxis, these are the main ones that you guys have to remember: leukotriene B4, complement 5A, and interleukin 8. Right? So these are the along with the bacteria and the degradation products. So bacterial products and degradation products are the ones that are going to be responsible for chemotaxis. Please make sure that you remember these ones. Now, Khaled was mentioning earlier the complements. So these are the different complements that are like special complements. You know, the other complements are basically all responsible for doing the membrane attack complex and the destroying like part of the process. Now, the complements that have a certain or different function are complement 5A for chemotaxis, complement 3B, which is responsible for opsonization and macrophagous phagocytosis, and complement 3A, 5A, or like both of them individually, are responsible for mast cell degranulation. Now, these are the ones that I got from the patho, like from my patho notes that I had last year and from like the lecture. However, if you go back to the immuno lecture, I do remember that Dr. doctor mentioned C4B. Yeah, I was gonna say that. So he mentioned C4B or C4A, I'm not sure, in the immunology lecture. So do like make sure of that part. What exactly is the C4? But the ones that I remember from patho were these three ones, and there's something to do with the C4. So do revise that one. Now for mast cells, they're going to be releasing histamines and leukotrienes. Histamines, again, we said is responsible for vasodilation and permeability. Okay? It's for tagging C4B. Honestly, wallah, I'm not really sure, so I can't really tell you if it's right or wrong. But I think it was related for something like that. C4B will be in the complements. All of them, like all the different other complements that we didn't mention, will be part of a certain pathway of the complement membrane attack complex. However, like other than the membrane attack complex, what complements have a different function? These are the ones, C3A, 5A, C5A, and C3B. And there was something to do with C4. However, I'm not really sure. So like you will find it in the immuno slides. I can look for it after the lecture if you guys want. But let me finish up this now so that we don't want to take from your time. Okay, so leukotrienes. Now, the way I remember leukotrienes is that they are responsible for constricting everything. So constricting on the blood vessel, constricting on the bronchioles of the lungs, so bronchoconstriction and vasoconstriction. And leukotrienes are responsible for constricting of the blood endothelium cells. And what happens is that, like, if this is the muscle right here, so this is an endothelium, this is endothelium. When you constrict it, you're basically making it shorter, so you have more space for permeability. So if these are two endothelium, I constricted them. Now there's increased permeability. So like always associate leukotrienes with constrictions. And lastly is the macrophage activation, which I told you is very, very, very high yield, that you need to know how exactly we form the giant cells. You got interleukin 12s and interleukin 2, responsible for proliferation of the T helper 1 cells, and the interferon gamma is responsible for the formation of the giant cells. Okay? Is it all clear, you guys? We have 2 more lectures. And if you want to take the break now, let me know. And other than that, we can keep going. All good? Any questions? Keep going? All right, خلاص Shahd, take on the next question.
Yeah. 70-year-old woman has had worsening shortness of breath for the past week. On physical examination, her temperature is 38.3. On percussion, there is dullness over the left lung field. Thoracentesis yields 800 milliliters of cloudy yellow fluid from the left pleural cavity. Analysis of the fluid reveals white blood cell count 2,500 and 98% neutrophils, 2% lymphocytes. Gram stain shows gram-positive cocci in clusters. Which of the following terms best describe the process occurring in the pleural cavity? We got a couple E's. What answers? تمام. Okay, so everyone's saying E. Good job. Correct answer is E, purulent exudate. Can anyone tell me why that's the case?
This white fluid is pus, and another name for pus is purulent fluid.
Exactly, yes. So,
what is a third name for this process? Shahd, or anyone?
Suppuration.
Suppurative.
Exactly. So this is suppurative or purulent exudate. Now, okay, let's go through the options. Yes, okay. So suppurative or purulent inflammation.
Options or exudation?
Yes. So this is caused by certain bacteria staph, for example. So we said gram-positive cocci in clusters, for as you guys know from your micro, or basically any pyogenic or pus-producing bacteria. This would give us the edema, the liquefactive necrosis, and neutrophils, as you can see in red. So this is basically all. This will all lead to pus, and this will give us the purulent or the suppurative inflammation. Now, for other types of inflammation, for example, in serous, where do you see serous inflammation? Yes. Okay, good job. So you see serous inflammation in blisters, for example, so which is after burns, you can see collection of fluid, so that would be serous. What other types of inflammation are there? Quick review.
The fibrinous, bread and butter, and myocardium.
Exactly.
كمان في نسيت والله.
Bread and butter. Now this is
Bread
very
and butter
important.
is very important, yeah.
Yes. You need to remember it. This is characteristic for fibrinous inflammation. I think we have a question for that. I'm not sure, honestly. But fibrinous inflammation is related to bread and butter. This is very important. Have to remember this.
We had
Remember the
a
picture.
few cancer. I don't know what the
Sorry?
name of the inflammation is. Inflammation that has giant cells.
That's the caseous. Yes. So that
Granulomatous.
So the
Granulomatous.
formation, yes, the formation of any granuloma would have giant cells. So you have different types of giant cells. You have the Langhans giant cells, and you have other types of giant cells. So depending on the type of granuloma, you'd have different types. So you have the. Does anyone know any other type of giant cell?
Two-tone and foreign body.
Exactly. So this would differ according to the shape of the giant cell. So you'd either have the horseshoe shape, or they'd be neatly arranged in a circle, and so on. But basically, these giant cells, yeah. So these giant cells would be involved in granuloma formation. So you have the granulomatous, you have the suppurative purulent, you have the serous, you have the fibrinous or the fibrinoid, and so on. Any questions? So I think we can move on.
You want to go through the choices, or خلاص you guys are good?
I think we discussed them.
Alright. So next question. A 58-year-old woman with diabetes and hypertension. She has an end-stage renal disease. A shaggy fibrin-rich exudate is noted on the pericardium. Which of the following best explains the pathogenesis of this fibrinous exudate? C and D. Give you guys a chance to try and answer this question. So fibrinous exudate that can be seen, and right, this is the fibrinous exudate. So 2 C's, 3 C's, and 1 D. Also, any more answers? Does anyone try to answer? All right, also show the answer then.
Whoever answered C, the correct injury and increased vascular permeability. Now, we can move on to the next slide. Yes, so as you can see, it's stated clearly in your slides, we'll get an increase in vascular permeability. Again, as we mentioned previously, any increase in permeability, substances will now be able to leave into the tissue. One of those substances in this case would be fibrinogen. And now, as we know, fibrinogen would be converted into fibrin. Fibrin would cause the fibrinous inflammation from its name. So this would cause the bread and butter appearance. As we explained previously, bread and butter is associated with any fibrinous inflammation. So as you saw in the image, this would be associated with the myocardium, or with the heart, I mean. So in this case, we had fibrinous inflammation due to the passing of fibrinogen and fibrin. And what allows this passing is the increase in vascular permeability. Is that clear? We can see, as mentioned in the slide, this is an inflammation in any of the body cavities. So the meninges, the pericardium, and the pleura. In this case, we had the pericardium and the heart. Anything else?
All right. So let's go to, okay, never mind. We're done with the lecture. So I didn't really include the summary right here, but Shahd and I will give you like a quick summary for this lecture, what you really need to know. So basically you have the different patterns. You got the serous. So serous is always associated with empty fluids, right? So any clear fluids is serous. If you get a question about fibrinous, then fibrinous is going to be increased permeability, bread and butter, or fibrin that is going to be found. Okay, so permeability, bread and butter, or fibrin that's going to be found associated with fibrinous. Now, you also got the granulomatous. So granulomatous is going to be associated with the formation of granulomas. And we said, what is the key hallmark for any granuloma? What is the key hallmark for any granuloma?
Giant cells.
Exactly. So for granulomatous, you got the giant cells, which is your key hallmark. And I think that was all. I'll try to add a summary like before we send you guys the lecture. We'll add a summary quickly for that. All right. Now, with that being said, we're going to our last lecture, which is chronic inflammation. All right, let's go to
I just want to add one last thing to that lecture. Now we also have one specific case in which there is a break in the continuity of the covering epithelium.
Ulcer.
What do we call this? Yes, sorry?
Ulcer.
Yes, exactly. So this is really important. Whenever you see a histoslide with a break or like a joint dip, a hole in the epithelium, this would be associated with ulcers due to the break in the continuity of the epithelium. Now, this is a very high concept also, and it's very possible you get it in your exam too. So yeah, I think that's all for that lecture.
Pictures in that lecture are really, really important. Also, there was the abscess. So the abscess is like just a small, like, you know, curve up in the epithelium like that. So like pictures are really, really important in that lecture. So make sure that you're really familiarizing yourself with them. And all right, so let's go to the last lecture, chronic inflammation. All right, so a 53-year-old man develops weakness, malaise, cough with a bloody sputum and not sweats. Chest X-ray reveals apical densities bilaterally. Exposure to TB was documented. And basically, the patient dies of respiratory insufficiency, which of the following characterizes the histopathological features of this pulmonary lesion. So a bunch of E's and a bunch of B's. Right, so the correct answer here is E. Now, for the person that answered B, I'm not going to tell you that you're 100% wrong because TB is a chronic inflammation because it's a long-term infection. And as you can see in the scenario right here, it is 20 years ago. Like, however, like the more specific or like the most specific answer and like a better answer right here would be a granulomatous inflammation because granulomatous inflammations are the ones that are going to be associated with TB. So if you do get this question in the exam and you do see that both choices are there, even though chronic inflammation might be right, but like the more specific and the more correct answer is granulomatous inflammation. So like something that I did a lot in the past exams is that I will see two choices and I will see one that is 100% right and then one that is 30% right, and then I'll go for the 30% and I'll get it wrong and they reject the appeal usually. So if you get a choice like that, always like go for the more specific answer that you get. Can we appeal it? Honestly, I think if you did appeal such a similar question, they might accept it. But like, don't put yourself in a risky situation. Like, just go for your granulomatous. But I think they should probably accept the appeal because it is a chronic inflammation.
لا بس يعني chronic inflammation is general. The question is saying what characterizes TB. A character of TB. Anything could be chronic inflammation. What's character for TB is the granulomatosis. It's not appealable.
That's true. Characterizes, which is basically like why granulomatous is the better answer for this choice because it's like asking you for which one following characterizes it. But yeah, so the chronic is not 100% wrong. Let's just go for granulomatous because it is the characteristic one and it's the better choice right here. And yep, as you can see right here, basically, does it say joint cells in this picture?
It says granulomatous in nature. Yes, for tuberculosis.
Yep, so TB is going to be for the specific chronic inflammation. All right, next question.
Tamam. A 41-year-old woman complains of excessive menstrual bleeding and pelvic pain of 4 months. She uses an intrauterine device for contraception. Endometrial biopsy shown in the image reveals an excess of plasma cells and macrophages within the stroma. The presence of these cells and scattered lymphoid follicles within the endometrial stroma is evidence of which of the following conditions? We got a few B's. Okay, so everyone answered B, which is the correct answer. We have many clues in the case. First being the 4 months, so it's a long period, so it can't be acute. It has to be something prolonged. And we don't see granulation tissue. Granulation tissue, basically you'll see blood vessels forming and so on. In this case, there was nothing mentioned about that. Granulomatous inflammation, as we said, is involved with the giant cells and so on. And we have the, and in this case, we don't have any giant cells. And menstruation, finally, the case does not explain anything about the case, okay, is about excessive menstrual bleeding, but what they're asking about is the inflammation happening and all the plasma cells and the macrophages. So in acute inflammation, we'd have more of neutrophils. In the chronic inflammation, you'd have more of the plasma cells and the macrophages and the other types of cells. So here, the main clues are the 4 months, which is the prolonged period, and we have the plasma cells and the macrophages instead of the neutrophils. Is this question clear? I think this is our last question. Do we have more?
No, so that's the last one. So I just want to add last thing, as Shahd mentioned. So the key hallmark for chronic inflammation is the presence of lymphocytes, such as this one's right here. So lymphocytes, whenever you see lymphocytes, then this means it's a chronic inflammation. All right, and with that being said, we're done with our lecture. So I added this other picture right here for you to describe the structure of a granuloma. So you have 2 types of granuloma. You can have a caseating or non-caseating. A caseating granuloma will have necrosis in the center, while a non-caseating will have no necrosis. However, the peripheral structure is going to be the same. So you have the necrosis in the center, surrounded by your macrophages. What are the macrophages? You have the giant cells, very important giant cells, and sometimes you can even have epithelioid cells. What are epithelioid cells? They're other type. What are giant cells? Do you guys know what are giant cells exactly? Oh, never mind. It's in the slide. It's macrophages. Okay. So yeah. So basically, giant cells and epithelioid cells are activated macrophages and mature macrophages. Right. So they're going to be found right there. And lastly, like on the outside, you will have your lymphocytes, helper T cells mainly, and you can have like other type of lymphocytes, which can be seen in this area. Now, this here is a picture from Boards and Beyond, which is basically describing the process of activation of the giant cells, how exactly the macrophage will do it. Basically, you got the CD4 positive helper T cells. And again, we said what type? It is T helper cells type 1, right? Now, basically, these guys will release interleukin 2. Interleukin 2 causes more proliferation of the T helper 1 cells. So interleukin 2 acts on itself, while interferon gamma will activate the macrophages. Okay, and once the macrophages are active, you will have your giant cells. And with that being said, we're done with our lecture. So please fill the QR code, and if you have any questions, here's my contact number. Here is Shahd's contact number. Feel free to contact us if you have any questions. And so yeah, with that being said, I looked up on my notebook a part. 1 second. Wait, how do I end the slideshow? Okay, so yeah, looked up on my notebook the part for the complements. So on my notebook, it says that there's complement 3A, 5A, and C4A are responsible for the mast cell degranulation. This is from the immunology lecture, and it's called anaphylatoxins. That's what they call them on the microbiology lecture. So do, however, check on your microbial, immunology, not micro. So in immunology, this is what I have them. However, do make sure in your lectures, and also in my notebook, I have this 3A and 4A and 5A, underlining the letter A, underlining it with anaphylatoxins. So basically, that's how I remembered it, I guess. So the A's and the anaphylaxis. And any type of anaphylactic reaction is going to be associated with an allergic reaction. So allergic reactions are associated with histamines. So if we say anaphylatoxins, then they're going to be mediating an allergic reaction, which is going to be through histamines and mast cells. And it's, I guess, 3A, 4A, and 5A. However, the 5A is chemotaxis. This is very important. 3B is opsinin and phagocytosis. And so, yep. Oh, wait, also on my notebook, it says that C4B act as an opsonin for phagocytosis. But C3b is the main effector. So C3b is the main effector, but C4b also acts for phagocytosis. And yep, so 3A, 4A, 5A are anaphylatoxins. C5A is a chemotaxi, and C3b and 4B are going to be for opsonization. Right. So any question, guys? Oops. Let me go back to that slide.
Thank you guys so much for interacting and everything. If you have any questions, your contact numbers again. And best of luck for your exam. So let's go
Best of
well.
luck. Feel free to text us for any questions, and good luck on your exam. Thank you, everyone.